Thank you for that kind introduction, Dr. Hahn, and thanks for everyone for attending. Hopefully we'll be transitioning here to another interesting and important topic. So we want to talk a little bit about what the future is for carotid disease and its management. These are my disclosures. So, historically, we've used endarterectomy to treat carotid disease, to remove the source of embolization and prevent stroke for patients who have high-grade carotid stenosis, and that's proven to be highly effective and remains highly effective. We've had some other advances. We utilize angioplasty and stenting. That really started back in the early 2000s. And if you look at the trials over time, you've seen continuous improvement in outcomes for these independently adjudicated trials. So these are all pivotal trials that will show improving outcomes, and that's showing improvement in techniques, certainly improvement in the technologies that we utilize in terms of stents and embolic protection, but perhaps most importantly is our patient selection. And at Sinai with Dr. Krishnan, we always discuss these patients with carotid stenosis and what's going to be the optimal approach. So patient selection, I think, is certainly essential to the management of carotid disease. And then, the basis of our treatments, at least what we'd like to see, is level 1 evidence, these randomized prospective trials. And so the CREST trial, as I'm sure most of us are aware, looked at the treatment using stenting and endarterectomy and compared them directly. And if you look at the aggregate endpoint of major adverse events within 30 days and then ipsilateral stroke out to 4 years, you see that angioplasty and stenting and represented here and endarterectomy represented here had equivalent outcomes with regard to that aggregate endpoint. You do see, though, that there's a higher myocardial infarction rate for endarterectomy as compared to angioplasty and stenting, but a higher stroke rate for angioplasty and stenting as compared to endarterectomy. And these were both statistically significant. So again, it's really patient selection. Does the patient have compromised coronary perfusion? Are they going to do better with an angioplasty and stenting, or is it a heavily calcified lesion that's not going to respond well to angioplasty and stenting and should be treated with endarterectomy? Again, patient selection, I think, is the key to that future. Oops, sorry about that. And the other interesting finding, and really does guide us in terms of treatment, and will continue to do so into the future, I think, is looking at the specific patient characteristics. And if you look at this CREST trial again with these randomized patients, sort of contrary to what we had anticipated, you see that the older patients actually do better with endarterectomy, and younger patients do better with angioplasty and stenting. And that, again, reaches a point of statistical significance, so an important consideration for the future. So how can we improve these outcomes for angioplasty and stenting? I think our techniques for endarterectomy have really reached a mature phase. Obviously, we want to optimize medical management of those patients, reduce the risk of MI and other associated perioperative complications. But for our techniques with angioplasty and stenting, one thing we see is if you look at this OCT image, you can see prolapse, or hopefully you can see prolapse of the plaque through the interstices of the stent. So that's a real consideration, because that still can be a potential source for embolization even after the procedure has been completed, your embolic protection has been withdrawn, but that plaque, as it prolapses through that open cell area, is a potential for embolization. And you see this in a couple of trials that have looked at open cell versus closed cell stents. And it appears that the closed cell stents, because of that smaller free cell area, that smaller area of interstices between the stent struts, has less embolization. And you can see that on a diffusion-weighted MRI. And we actually conducted a trial looking at captured particulate in the filter itself and saw larger, unsurprisingly larger particles for the open cell stents as compared to closed cell stents. So that's an indication as far as the technology. And it's really even gone a step further now. These mesh covered stents, so you have your sort of standard nitinol stent, and then you have a mesh of either Gore-Tex or PTE on it with a very fine pore size that's going to trap the potential embolic debris against the arterial wall outside of the stent and prevent embolization. So again, these mesh covered stents, I think, could be an important technological advance. Proximal protection Also seems to afford very good embolic protection. You don't need to worry about filter positioning and filter apposition to the internal carotid wall because you have flow reversal, or at least flow cessation when you're doing the angioplasty and doing the stenting. You're evacuating all that blood that may have debris within it. And that's shown to be effective. This is just a case that we utilized proximal protection. Here's this terrible high-grade ulcerated unstable lesion. We occlude the external carotid, we occlude the common carotid, and then when we aspirate, we're sucking all that blood back out of that stented area. And here's just our completion arteriogram at that level, showing good resolution of the stenosis. So that can be quite effective, and the pivotal trial data bear that out. And remember, we saw in the CREST trial, the patients older than 70 did better with endarterectomy. They did worse with angioplasty and stenting. But if you look at proximal protection, they seem to do pretty well. These are octogenarians within that Empire trial, and they had a very acceptable perioperative complication rate. So maybe something to be utilized, particularly in high-risk patients. And clearly, there's going to be an ongoing role for angioplasty and stenting in a variety of sort of anatomic challenges. Here's a patient with neck irradiation. They've got a laryngeal stoma, so you're not going to be doing a TCAR. You're not going to be doing an endarterectomy in a patient like this. The really only option for treating them is going to be angioplasty and stenting. For restenosis, angioplasty and stenting is very effective. It's low. It's more of a fibrotic lesion, a restenotic intimal hyperplastic lesion, so very low embolic potential. So the angioplasty and stenting itself is safer, and the risk for cranial nerve injury for endarterectomy, for repeat endarterectomy, is quite substantial. So angioplasty and stenting clearly the most advantageous way of approaching that. Here's a restenotic patient of my own. It's the only one I've ever had restenosis. So that may not be true, but anyway, it's a recent. Actually, I don't think this was my patient, but they've got this weird, right in this endarterectomized segment, very tight restenotic lesion. You can see the clips from the prior surgery, so I guess it wasn't mine. And here we're doing the angiogram, and you can actually see there's even a dissection right here. You can kind of visualize in another area of potential dissection in this endarterectomized segment, and then beyond where the endarterectomy was, it sort of normalizes a little bit on the small side. And you can see here I am jamming a BMW wire into that dissection, so that's not you try to get out, stay out of the dissection whenever possible. But in this case, we're able to ultimately traverse the stenosis, get our embolic protection device up, and treat it with angioplasty and stenting. So with dissections, I think there's no question that angioplasty and stenting is going to be more advantageous, and restenosis as well. And of course, the incidence of concomitant cardiac and coronary disease in patients with carotid disease is extremely high. In fact, the most sort of predictive finding for a carotid bruit is the presence of significant coronary artery disease. So a lot of these patients are going to have high-risk physiologic conditions that, again, respond much more favorably to minimally invasive treatments. The other thing that we're sort of seeing more of, and I think is going to continue to have a role into the future, is this transcarotid angioplasty and stenting. And it's sort of a clever idea. It does require a cervical cut down. But what you do is you introduce a sheath and then connect it through tubing and a filter into a femoral access. And so the blood is flowing in the reverse direction from the internal carotid through the tubing and filter, and then back to return to the circulation via that venous catheter. So you can do your angioplasty and stent procedure through a nice short sort of runway in the neck, so you don't have to negotiate type 3 arch, any sort of occlusive aortic disease, proximal tortuosity or disease in the access vessels can all be avoided. And your embolic protection is quite effective because you reverse flow. And here's just sort of a diagram of that. So you have your little introducer sheath which is placed directly into the common carotid artery. And here's that sheath. And then you can do the angioplasty and stenting, but when you occlude the common carotid artery proximal to the sheath, and so now flow is going down that pressure gradient, down through that lower resistance into the venous circulation. And so any debris that's liberated during the placement of that stent travels through the filter in the circuit and is eliminated in that fashion. So they've seen pretty good results. This is their pivotal trial. The aggregate stroke death and MI rate at 30 days is very acceptable, 3.7%. And if you look at stroke and death, it's 2.3%. So it's not foolproof. Obviously, there are still some complications in these patients, as we see in all patients treated for carotid disease, or the potential for that in all those patients. But really, it seems to be highly effective and can be a a real adjunct when you need to treat it with a stent, but you can't get access, via transfemoral route. The other thing to consider for the future is best medical therapy for these patients. And Ross Naylor and other colleagues have looked at, these are the randomized trials, but looking just at the medically managed arm. And if you look at the stroke rates, they've come down, since the 80s, basically, and through the 90s and into the 2000s and 2010s even, to where the medical management of these patients have very low annual stroke rates, much lower than obviously 2 or 3 decades ago. And we think that's a reflection of the improvement in medical management of these patients. The thing to consider is that the perioperative event rates have also come down over the same time period. And again, some of that's advances in technique and patient selection technology, but some of it is medical therapy of those patients. That also helps to reduce stroke, incidence of stroke and other complications in the perioperative period for treatment. And this just sort of further illustrates that. If you look at the medical arms of these trials, you had a stroke rate that was 11% in ACAS. Then in the first 5 years of follow-up for ACST, it was 5%, and now it's down to 3.6% in the 6 to 10 year follow-up arm. So again, that's just a reflection of the improved medical management of patients with systemic atherosclerotic burden. The other thing to look at is, when we treat asymptomatic disease, we estimate we have to treat 11 patients with asymptomatic carotid stenosis to prevent a single stroke. So 10 of those patients, our treatment really wasn't, from a statistical standpoint, accomplishing anything. So how can we be more selective and figure out which asymptomatic patients are really at high risk for that high-grade lesion creating a stroke, and which ones maybe can continue to be managed medically? And so a number of factors are being looked at. Percent stenosis obviously is something we've always sort of used as a surrogate for embolic risk or plaque instability. Grayscale median, those echolucent plaques seem to be more prone to degradation and embolization. The total area of plaque that's accumulated seems to also have an influence in that. And then looking at MRI of the brain in terms of any evidence of prior asymptomatic embolization. And if you use all these factors in aggregate, you actually can get a pretty decent prediction of which asymptomatic stenoses may be the highest risk. So again, just a potential for advance into the future. One final thing to look at in terms of advances in the future is the impact of carotid stenosis on neurocognitive function, and then the improvement in neurocognitive function with correction of the stenosis. This is sort of in its nascent phase, but there does seem to be some evidence that by removing this source of microembolization, we may improve neurocognitive function. So I would just conclude that the techniques and technology continue to improve. These mesh covered stents, I think, offer some potential further improvement in terms of minimizing embolization. Flow reversal really doesn't require a good wall apposition of a filter and doesn't have any pore size, and so that's another potential improvement. And then this impact on cognitive function, I think, is going to be important into the future. So thank you very much.